believe Doppler is such an important part of every routine exam. You should perform Doppler, of course, in every patient. And you can use post-wave Doppler, you can use continuous wave Doppler, you can use color Doppler, and even tissue Doppler. In the following slides, I would like to show you where you would use which technique and what is part of a routine exam, what the normal measurements are, and what information you can get out of Doppler. Let's first take a look at the list of different positions and techniques you would use. The first important thing is that you perform a post-wave Doppler exam of the mitral valve in every patient. In addition, you should measure the velocity across the aortic valve with the help of continuous wave Doppler in every patient. You should also look at the pulmonic valve. You can do that either with continuous wave Doppler or with post-wave. And also try to measure the tricuspid regurgitation signal with a continuous wave Doppler. And finally, I also believe that it should be part of every exam that you perform a tissue Doppler velocity measurement of the mitral annulus. Additional features or additional components of Doppler that you might use under special circumstances is the measurement of post-wave velocity, forward velocity across the tricuspid valve, the post-wave Doppler of the LVOT signal, measurements of flow in the hepatic veins, usually with post-wave Doppler, and also flow across the pulmonic valves, the pulmonic veins into the left atrium, also with post-wave Doppler. So these different techniques that you see on this slide don't have to be used in every patient. They should only be used under special circumstances if you have special questions. Let's first take a look at how to acquire a good Doppler signal across the mitral valve. To acquire a good signal of the mitral valve inflow, it's very important to have good image quality. So if you have a good 2D image, usually your Doppler images will also be good. Vice versa, it is sometimes still possible to achieve fairly good Doppler quality even if the image quality is not so good. But nevertheless, it's first important to optimize your image. So this is an optimized 4-chamber view. And just to demonstrate where to put the sample volume, I want to put the color in first, just to show you what the direction of flow is. In the normal ventricle, which is not dilated, the flow is directed more towards the lateral wall and then turns around and goes towards the LVOT. So to place your sample, you have to consider this and also consider that the posterior leaflet is shorter than the anterior leaflet. So this is the region where I have the sample volume now, where I would place the sample volume. It's not in the middle of the ventricle, but it's more towards the lateral wall. The next thing that is important is it's better to freeze the 2D image while you perform the post-wave Doppler. You can use the image as a reference, but in the long run it is probably better if you want to then do some measurements to freeze the image, because the quality of the Doppler is better if you freeze the 2D image. You can optimize the image. I would always want to see at least some information below the zero line, between the baseline, and then also optimize the velocity so that you get the entire spectrum, but nevertheless that you do not have unimportant information on the spectrum. So the location of the sample volume you can control. If you move the sample volume towards the mitral valve, what you usually get is you get very sharp echoes. And these echoes are caused by the valve itself, which closes, and you're right in the valve, basically. So this is probably too far down. So you'd have to move the transducer up a bit until these very sharp echoes vanish. And then you would freeze the image and perform your measurements. So what is the importance of the post-wave Doppler signal, or the Doppler signal across the mitral valve? The greatest importance is probably to assess diastolic dysfunction. But you can also look at the gradients across the mitral valve. When we talk about mitral stenosis, we'll talk about that in more detail. You can even see if the patient has sinus rhythm or atrial fibrillation, assess the presence of constriction or restriction, and it is also good to measure timing intervals, for example, the duration of diastole. The normal values for the Doppler signal, or the maximal velocity or E-wave velocity that you will find in patients, is not above 1.3 meters per second. So that is the reason you can easily use pulsed wave Doppler in all normal patients. You do not need continuous wave Doppler. Let's now turn to continuous wave Doppler across the aortic valve. The continuous wave Doppler across the aortic valve is very similar to the pulsed wave Doppler. Basically, you would perform it when you're expecting higher velocities. But there's just a few points that I would like to make. First of all, we have the same transducer position as we had before, 5-chamber view, but a bit more lateral so that you have a better orientation with respect to parallel alignment with the ultrasound beam. Then you would place the continuous wave Doppler beam across the aortic valve. And the only difference you have here is you do not have a sample region of interest, but what you have is you have a focus region. And this focus is of importance because if you move this focus point, you will all of a sudden get a worse quality of the signal. I'll demonstrate this here. Right? This is the focus point exactly at the aortic valve where we're expecting the highest velocity. If I move the continuous wave Doppler focus point away, the quality of the signal will degrade. I'm going back to the aortic valve, and you see all of a sudden the quality gets much better. So the point I'm trying to make is use the focus point of the continuous wave Doppler. You will greatly improve your quality of the Doppler. What is the continuous wave Doppler signal across the aortic valve good for? Its greatest importance certainly lies in the assessment of aortic stenosis. It is also possible to look at LVOT obstruction because your continuous wave Doppler signal transects also the LVOT. It is possible to look at gradients for aortic stenosis or for LVOT obstruction and thereby helping quantifying lesions. And furthermore, with the help of Doppler and the spectral tracing, it's possible to measure timing intervals, for example, the delay between the electrical and the mechanical ejection, the duration of systole, and many other features which are used in many different pathologies. So again, Doppler is very helpful in looking at timing intervals as well. The normal values for AV Doppler is 1.7 meters per second. So in the most patients, you will get a velocity somewhere in the range of 1, 1.2, 1.3. If you come towards 1.7, it's either a small aorta or it is a patient who has aortic valve sclerosis. But the upper limit, I would say, for a valve which is not stenotic is 1.7 meters per second. For the pulsed wave Doppler signal across the LVOT, it is important to first acquire a 5-chamber view. So we'll start with the 4-chamber view. This is the 5-chamber view. To optimize the 5-chamber view for the LVOT measurements, I would recommend that you move the transducer a bit more lateral. And if you do so, what happens is that you are oriented much better with respect to parallel alignment of the ultrasound beam than the classical 5-chamber view. And so in this view, I would then place the pulsed wave Doppler signal in the aortic valve, then optimize the baseline and, of course, the speed with which you were recording. What you have here is now you have very sharp echoes. This means you're right in the valve. And so from this position, I would go back a bit until you're safely in the LVOT. This is usually when those sharp echoes are gone. Okay? You usually see that the velocity is a bit lower here as well. Okay, so this would be a very nice signal, and here you could actually perform all the measurements you would want to do. What is its importance? As I already mentioned, for LVOT obstruction, for the calculation of the aortic valve area, because you need the information of flow velocity in the LVOT in the formula which is called the continuity equation, for the calculation of stroke volume and shunt volumes, and in addition, or also for the timing of certain events, very similar to the other signals we've heard so far. The normal velocity in the LVOT is approximately 1.3 meters per second. Now let's take a look at the flow studies within the pulmonary artery and across the pulmonic valve. So this is how I would perform a PW Doppler evaluation of the pulmonic valve and of the pulmonic flow. First of all, we need a short axis view where we demonstrate the pulmonic flow. This is first, we'll try to optimize the view a bit. This is much better. Then we place the pulsed wave Doppler spectrum not in the RVOT, somewhere here. And I would personally also not put it here, but I would put it right exactly in the valve. So this is where I would put the pulsed wave Doppler signal. And then optimize the view. And you can perform all the measurements you would like to perform. The pulmonic signal can be used to measure the degree of pulmonary stenosis, to assess pulmonary hypertension, and to calculate the right ventricular stroke volume and thereby help in the assessment of shunts. With the help of color Doppler, you can see pulmonic regurgitation. The normal values of the velocity across the pulmonic valve are usually 1 meters per second, that is the upper range, depending of course on the size of the valve and the size of the pulmonic artery. Now let's take a look at the tricuspid valve and the Doppler signals across this valve. What is the signal good for? Well, basically you would only perform the signal if you have the suspicion that the patient, for example, has tricuspid stenosis. You can see a signal here, a normal signal across the tricuspid valve with an E and an A wave. And you will also note that the velocity across the tricuspid valve is lower than that of the mitral valve, which is explained by the fact that the tricuspid valve is actually larger than the mitral valve. Typically, you would see respiratory variations of the signal, and these variations can be very pronounced in situations such as restriction and constriction, but we'll talk about that later when we come to the corresponding chapter. The normal value is lower, as already mentioned, than that of the mitral valve, so the upper limit is somewhere in the range of 0.7 meters per second, but with higher velocities during inspiration versus during expiration. More important than the forward flow across the tricuspid valve is the assessment of regurgitant velocities through the tricuspid valve back into the right atrium. The importance lies that it allows you to measure the pulmonary artery pressure, as we will then later see when we come to the chapter on pulmonic hypertension. This is such a signal of a tricuspid regurgitant jet where we can nicely see the maximum velocity, which lies just barely under 3 meters per second. So this is a signal that you will need very often because very many patients have at least mild or moderate tricuspid regurgitation, and that helps you to assess pulmonary pressure. Other than that, you can use the continuous wave Doppler across the tricuspid valve for forward flow if you have the suspicion of tricuspid stenosis and if the velocities are very high, but usually it would be sufficient to use pulsed wave Doppler across the tricuspid valve, even in the setting of tricuspid stenosis. The normal values for the TR signal in Doppler are 2.3 meters per second. This would denote normal pulmonic pressure. Another application of Doppler, this time of tissue Doppler, is that of measuring the velocity of the mitral valve annulus. This is very important in the setting of diastolic dysfunction, and let's take a look how we perform that. In principle, you have two possibilities to assess the velocity of the mitral annular plane, either at the medial vicinity or at the lateral vicinity. So I'll first show you how to do it at the medial portion of the mitral valve ring. The first thing is you try to get the spectrum as small as possible to enhance or increase your frame rate. Then you put the color Doppler, the tissue Doppler spectrum over the medial annulus, and then you put the pulsed wave Doppler signal right at the area where the ring is, and you will receive a spectrum which looks like this. What can you see? First of all, you see systole here, and you see diastole here. This is the E wave, and this is the A wave. What you would need for the E to E prime ratio is this velocity. In this case, it would be 0.12. So you had normal E velocity of something in the range of 6 or 7, so the ratio would be somewhere in the range of 5 to 7 would be his normal E to E ratio. You can also perform the measurement at the lateral ring. All you have to do is switch the region of interest to the lateral ring, then put the pulsed wave Doppler signal there, and again we get an E wave or E prime wave and an A prime wave. Here the maximum velocity is 0.18, so you will usually see a much higher velocity of the tissue Doppler E prime wave with the lateral ring opposed to the medial ring. But tissue Doppler can not only be used for the mitral annulus, it can also be used for the myocardium, and I find it specifically valuable to assess right ventricular function. So this is how you would perform a tissue Doppler evaluation of right ventricular function. We do that from an apical position. We optimize the right ventricle. The next thing we do is we try to reduce the sector width simply because we increase the frame rate, which is important for tissue Doppler. Then we would put the color tissue Doppler display and the pulsed wave Doppler tissue display, freeze the image, perform a calculation of the maximum velocity during systole, which is 0.12, in this case normal. This is systole, this is isovolemic contraction, and here this is obviously diastole. In my view, tissue Doppler has two major applications in a routine exam. The first is the assessment of mitral annular motion, and thereby measuring filling pressures and diastolic dysfunction. And the second is right ventricular function, which allows you to quantify the motion of the lateral wall. Certainly there are many other applications of tissue Doppler which you can use in special settings, but these two are of particular value, and these two I would perform at least in most patients. The normal values for tissue Doppler are seen here, and what you immediately see is that the mitral annular velocity varies with respect to age, and the maximum velocity across the right ventricle should be above 10 centimeters per second. Now let's turn to color Doppler. Color Doppler, no question, is very important. However, I have the impression that the color Doppler is probably used too much, especially if you learn echocardiography. It has its place, but my impression is that you should probably stick with the 2D image first and try to get the morphologic information you need, and then turn on the color. But if you turn on the color, it's very important that you try to look for the aliasing of the signal, because that shows you where the turbulent flow is, that shows you where the high velocity flow is. Consider also the fact that you have to have a very high frame rate to improve your quality of the Doppler signal. We talked about that in the part on technical issues. And use multiple views, especially if you want to look at jets and in quantifying, for example, regurgitation in the setting of mitral or tricuspid regurgitation, because you have to get a true three-dimensional impression of the true size of the jet. So use multiple views when you turn on the color, and use the color also to guide you for your conventional continuous wave or pulsed wave Doppler. With the color Doppler spectrum, you know where the problem is, and then just place the sample volume in the right region. These are some examples of where I would routinely place the color Doppler sample volume in a peristernal short axis view
we can see if there's regurgitation or turbulent antegrade flow across the aorta, so I would place it over the aorta. But I would also put the sample volume towards the mitral valve and do the same for the mitral valve. So in the peristernal long axis view, color is very important. This is also important in the short axis view. In particular, when you look at the pulmonic valve, here, for example, you would have a small pulmonic regurgitation jet, and you can see the forward flow, and you can note if there's turbulent forward flow, which denotes, for example, stenosis. This is another short axis view, which shows you the aorta here at the center, and here the normal inflow of the vena cava. Also, the short axis view is important, for example, to look at atrial septal defects, which would be located here. And this is a long axis view, a peristernal long axis view of the right ventricle, also very valuable to look at regurgitant flow at the tricuspid valve. Some more examples now from an apical window. The mitral valve, assessment of mitral regurgitation. The tricuspid valve, assessment of tricuspid regurgitation. The 5-chamber view, where you see aortic regurgitation, turbulent flow, for example, in the LVOT or across the aortic valve, and in an apical 3-chamber view, where you can look at both the mitral and the aortic valve, similar as you would see it in a peristernal long axis view, with the only exception that now you have a different angulation between the color jet and the transducer, which has certain advantages, especially in situations where the jet is oriented more parallel to the ultrasound beam. Some more examples. This is a subcostal view of the vena cava, where you can use the color to assess the retrograde flow, for example, into the hepatic veins and normal inflow into the right atrium. This is a subcostal short axis view where you can, similarly as with the peristernal view of the pulmonic valve, look at regurgitation and turbulent flow, and a suprasternal view looking at the flow in the descending aorta to see if you have retrograde flow or not. So in summary, color Doppler is very important and should be an important part of every exam. I showed you some typical practical applications of color Doppler, but there are many, many more, as you will see when we come more into the pathologies, where we see the power and the full potential of color Doppler. So let's summarize the chapter on how to image. There are several windows from which you can view the heart: the peristernal, the apical, the subcostal, which should be performed exactly in that sequence. And then you have additional views, such as the suprasternal view and the right peristernal view, which have their applications in certain clinical situations. There are several peristernal views, so-called long axis views. There's a peristernal long axis view of the left ventricle and a peristernal long axis view of the right ventricle. There are several short axis views, which are approximately 90 degrees to the long axis views. The first one that you would perform is the one at the base, where you have the aorta at the center and the structure surrounding the aorta being the left atrium, the right atrium, right ventricular outflow tract, and the pulmonic artery. If you tilt the transducer downwards, you would get a short axis view of the mitral valve, with the mitral valve here at the center and the LVOT. If you tilt the transducer even further, you get a short axis view where you have portions of the mitral apparatus visible. And if you tilt the transducer even further down, you get a short axis view where you have the papillary muscle. The short axis view are important to assess the function of the aortic valve, for example, and left ventricular function and the mitral valve. The apical views are performed from the apex, which lies somewhere in the region of the fifth intercostal space. The probably most important view being the 4-chamber view, with the left ventricle, left atrium, and right atrium visible. And then you can rotate the transducer around the center axis, and you would get the 2-chamber view and the apical long axis view. And if you tilt the transducer upwards, you would get the 5-chamber view. There are special additional views which I find very helpful for imaging. This is the so-called coronary sinus view, which you get by tilting the transducer in opposite direction than to the 5-chamber view, and thereby you visualize the coronary sinus. You can place the transducer in a more lateral position, and thereby you would get a view where the septum points to the left of the screen. This view is very helpful to assess right ventricular function. You would see the right ventricle very nicely. You can also rotate the transducer clockwise and thereby get a view where you have a very nice visibility of the lateral walls here. The subcostal views are very important as well. You can get a view which is very similar to the 4-chamber view, but this time you have the septum slanted more towards the right of the screen. You can see the pericardium very nicely and the 4 chambers. Short axis views can be performed from a subcostal approach just the same as for a peristernal approach. Again, a very similar view than we've seen before. The short axis view at the base with the aorta in the center. We have short axis views of the left ventricle, and we can perform a view which allows us to see the vena cava inferior as it enters the right atrium. This view is particularly helpful for the assessment of right atrial pressure and other pathologies which involve the inferior vena cava. The suprasternal view is a view that you will need in special situations, in particular if you want to look at retrograde flow or dilatation of the aorta, and the view shows the following segments. You have the aortic root with the ascending part and the descending part, and the right pulmonary artery which undercrosses the aortic arch. In summary, it's also important that you always follow a standard protocol. Start with the peristernal window, then switch to the apical windows, and then perform the subcostal window. Always use all standard views that I showed you, but feel free to also use other views, atypical views, and that you focus exactly on the pathology or the region of the heart that is of interest to you. M-mode still has its importance, but basically only in 2 applications. First, measuring the size of the aorta in the left atrium, and second, measuring the left ventricle, the septum, and left ventricular function. Doppler should also be performed in every routine, especially across the mitral valve, especially across the aortic valve, but you can also use it for the tricuspid valve, and you can even perform tissue Doppler. Doppler allows you to measure velocities across the valve or even within the heart, and also timing of events, and color Doppler helps you to note where turbulences are, which then again might help you in assessing the velocity or the pathology there.